Hello and welcome to the I Am Fearless podcast. I'm your host, Vickie, and man, am I glad that you decided to click and spend a little time with me today. Today's guest is Forkner. She is a physician's assistant and she works in an outpatient clinic here in Plano, Texas. The clinic that she works at is called Radiance Women's. I actually have been a patient at Radiance Women's for maybe over 2 to 3 years now, and the lead physician there, her name is Dr. Jackson. She is phenomenal, you guys. If you're in the market for an OBGYN, I recommend Radiance Women's, hands down. And actually, Dr. Jackson is the one who delivered Cairo. So today I was blessed with the presence of Forkner. She is bright. She is sharp, you guys. The amount of information that gives in this episode is mind-blowing. So I'm really excited and honored to have had her here on the show. We were recording from home because the baby's been sick. So you might hear the baby in the background a couple of times, and my apologies for that, but I'm starting a business and you know how that can go sometimes. But anyways, without further ado, here we are. Womb care, periods, what's normal and what's not. All right, enjoy. So you guys, I have two with me here today, and we have come up with the idea to talk about cycles. What is normal and what is abnormal. And you guys, It is so much stuff here. I'm literally going to just let take over, because I know that you guys have I know for sure you guys have as many questions as I did, because I got them. I got all 150 of those questions.
We had a lot.
We have a lot of questions, and the episodes are only 30 minutes. So, but you know what? I'm hoping that will come back and join us, because there's so much here. So, please take it away.
Okay, well, thank you so much, Vickie, for kind of giving me this opportunity. I feel like kind of the best way to start is just kind of setting a nice foundation for, what are our cycles, and kind of going from there. And so hopefully in that course, we'll kind of get a couple of questions answered along the way, because I know there's way too many for us to get to. So hopefully we can kind of get some answered as we're moving through. But cycles start when we are very young. So we are very accustomed to our cycles. Most of us get them kind of in our early teens. Some as young as 8 or 9. So we have some young starts out there, and we have them all the way up until we hit menopause. So for most women, it's kind of in your early 50s. Now, most cycles can kind of vary. So in our office, we kind of work within a range. So as long as your cycles fall within that range, then that for us is normal. So a normal length of a cycle can be anywhere from 3 days to 7 days. Most people have 1 or 2 heavy days of bleeding, and then it starts to kind of taper off over the course of that time. And then the days between the beginning of one cycle to the beginning of the next cycle can range anywhere from 21 to 35 days. So if you fall on the slightly shorter end, it's going to feel like you're having a cycle twice a month, because you can. Just with the number of days in between and the way the calendar works, you can actually have 2 cycles in a month. And for some people, if they're on the longer end, it might feel like they've skipped a month because of the same thing. They are falling just right outside of that window. And so we work, people hear a lot of that average number of 28 days. That's just an average. And so that's really how a lot of the contraceptives we use are based off of. It's based off of that average number, so that 28 days, which falls out to be almost a month exactly. And I would say, for most people during your heavy days, that's when you start to have a lot of issues. So when patients have heavier bleeding, that's when they can get cramps and things like that. But really, a normal flow for most people is on your heavy days, you're changing a pad maybe every 2 to 3 hours. So if you're bleeding more than that, then that might be a reason to go in and see your doctor. And then you can also notice some clots during the heavy days. They should be pretty small. And when I say small, I'm talking about maybe quarter size, nickel size, or smaller. If you're getting anything bigger than that, and I'll use my patient's words, right? Someone came in saying they had baseball size clots. If that's what your clots look like, you need to come in to be seen ASAP because that's quite a bit. But yes, and so definitely things to kind of look at. In terms of just tracking your cycles, I always recommend using a app on a mobile phone, and usually they will give you the average. And so if you fall within these range, then you are typically within our realm of normal for a cycle. Um, and then
Wow. Wow, that is
yeah,
crazy. And it makes total sense, right? Because especially when you're talking about, yeah, you would have a period once a month or twice a month because of
Mhm.
how the month falls or how it,
Yes,
yeah, yeah, no, I
yes.
did not think about it like that.
Yeah,
Thanks.
and I think a lot of people usually have questions like, "I think I skipped a month." And so a lot of times it's because of just the way it falls on the calendar. And so going off the calendar, yes, but based off of your normal pattern, you're still cycling the way that your body has always cycled. And so I think that's something kind of important to kind of mention because I think that's one of the main questions we get in our office too. Um, and then I think kind of going into that, the cycle itself is also kind of structured in a certain way. You have your follicular phase, which is kind of at the beginning of the cycle when your body is getting ready to mature an egg. And then you have your luteal phase after you've ovulated and your body's maintaining the lining in case we get pregnant. And so you always kind of operate in this little ebb and flow of we're preparing an egg and then the egg is out there and we're preparing for pregnancy. And if that doesn't happen, you kind of start the whole process over again. Now, when we are young and our ovaries are just starting to produce and just starting to function, our hormones are a little bit irregular. They're erratic because your little ovaries are like, "Ah, I have no idea what I'm doing." And so that is when we get a lot of cycle irregularities in our really young patients. So a lot of times it's just your body is really trying to get started, trying to figure out what it needs to do. And actually in our early 20s is when our cycles kind of stabilize. And that's what you really will see as your cycle up until right before you get to menopause. And then we go through like another phase of change again.
You know what? Actually, too, that was one of the questions that was submitted by my listeners. One of my listeners, they
Yeah.
asked about why they would have. Oh, I'm sorry. What she said is why in your 40s as opposed to your 20s and 30s do your periods change as far as dates and amounts and a lot of the times color.
Yes. So she touched on pretty much what you would expect in perimenopause. So when we say perimenopause, we just kind of say that time before you stop having any cycles. And so in perimenopause, you experience a lot of fluctuation in the way the ovary functions. And in that fluctuation, the hormones are also fluctuating. So you'll have some months where the ovaries are producing exactly what they need to, and you have regular cycles, and then you'll have some dips in hormones, and then you start to notice those changes. So you absolutely notice the number of days that you bleed will change. Initially, it's a little bit more chaotic. Patients actually notice worsening in their cycle. So the flow is a little bit heavier, the days last a little bit more, and it feels like the cycles are coming on a little bit more frequently. As you go through this process, and it can last up to a couple years for some people, you actually start to see the cycles lighten up, and then you start skipping cycles, and your body slowly spaces out the cycles until you have your very last cycle. And then for us, menopause is when you've gone a full year without a cycle. Once you've reached that benchmark, you really should not have any more bleeding. And so if you do, that is actually abnormal at that point. The other thing to note is that you also start to experience some other symptoms that are kind of going on at this time that might clue you into the fact that maybe I'm going through some changes. And they're more kind of bodily changes. So people will notice hot flashes, night sweats, changes in your energy. So energy starts to go down, changes in your sleep. Your sleep starts to get a little bit worse. Your metabolism starts to slow down. So then we start to see women gain weight, even though they have changed nothing. And so we start to see a lot of changes that kind of let us know that the body is just going through a change overall. And so sometimes you might get one thing. So it might be cycle changes that happen first, or it might be the vasomotor symptoms that happen first. And then eventually at some point, you'll probably experience both at the same time. And then hopefully you'll be through the whole process and they'll kind of all go away. But definitely very, very common. We see a lot of patients in our office for that. There are labs that we can do to kind of help see where you are in that process and to confirm if you've made it through menopause or not. And then there's also hormone replacement for women who have made that transition and are still experiencing some of those vasomotor symptoms. And just making that a little bit easier for them and a little bit more tolerable. But absolutely, you see a lot of change at the very end when you're done having cycles. I like to say that our cycles like to go out with a bang, so we don't forget that we had them.
As if they haven't been banging hard the entire time from, oh my goodness. That is, wow. So, okay, so you guys, like I said, I have received like so many questions from you all, and there's so much here to unpack. Another one of the questions that I had received, and you know what? Okay, listen, because you guys, we had chatted before we went on, and but I there was this question that I just looked at, and I was like, whoa, because this is new to me, and I literally don't have any knowledge about it, so I got to ask you. This is a surprise question too. Sorry.
Okay.
Now, I have a friend who got her tubes tied, and she wants to know. She says that now her pain with periods is now just off the charts, and like, why is it so painful? And then to second that question, what are some pain management things that you would advise for women having really painful periods?
Yeah, so I'll kind of touch base on the tubal pain first, and then I'll kind of circle back to the cycle pain. So with the tubal ligation, kind of the best way to describe it is that I think a lot of people just assume we go straight in, and when you close up, it's just the incision you're looking at externally. But to actually get into the abdomen, your surgeon, so your gynecologist, has to go through about 7 different layers of skin and tissue and fat to even visualize the tubes to remove them. And so you have to imagine in that healing process, you're healing each layer. The other downside is that the inside of our abdominal cavity is very sensitive and it's very easy to scar. I used to see this all the time when I was in general surgery. We would, take out gallbladders and do hernia repairs, but sometimes just as much as touching one of the instruments is enough to irritate the organ internally and can cause it to scar. We call those adhesions. And so basically it adheres itself to surrounding organs or to the surrounding muscle. And so a lot of patients after surgery will notice that if they turn a certain way or twist a certain way, they might feel more pain in their incision site. And a lot of times it's because they are pulling on that scar tissue. For some people, they think, if I have these adhesions, can I go in surgically and remove them? And you can. The downside is you risk forming new adhesions, and then you kind of are in this vicious cycle. So pain medicine works. I have found that there's a chiropractor we work with that is really good. He does a lot of myofascial work, but a lot of scar tissue, whether from injury or from surgery, you can actually massage out and you can break down that tougher scar tissue. And so that might be something you want to look into, because realistically, a lot of times that pain does not go away with pain medicine, because you're kind of trying to address like a function of something with medicine, and that structural change is not really going to be affected. Now, she may also have some other things, where going in to see her gynecologist, they can do a deeper workup, but I have seen a lot of patients after surgery, and sometimes it can be a little delayed. If they, a few years later, they're more active or they've made some big lifestyle changes and then they're noticing the pain, sometimes that's what they're noticing. But I would say that that's a very tough spot to be in. We have patients after hysterectomies, after tubules, after an exploratory laparoscopy where they can get that residual scar tissue and it can cause that lingering pain, or even like a C-section. They notice that pain right at the incision. And then to kind of dive into pain medication. So I like to just kind of describe how cramps work. So we have our lining, it grows in the uterus. And then when your body's like, no baby, it sheds that lining. And so your cervix, which is kind of the entrance into the uterus, it's about 3 to 5 centimeters long, but it's like a little cylinder. And so it's typically closed and it's pretty small. So as you're shedding this lining, the uterus is physically squeezing down on that cervix, trying to push all the lining through. And that's actually what triggers the cramping you sense. And so for people who have heavier bleeding, the cramping is heavier because you're passing more lining and larger clots through. With people with really light cycles, they tend to have lighter cramps because you're passing less things through. I find, Motrin is a good option. Really, ibuprofen is one that we use a lot because the non-steroidal anti-inflammatory meds, really kind of target the pain receptors within the uterus. The other thing I try to tell people is that if you know your cycle is about to come on, start the pain medicine earlier. So pain medicine binds to pain receptors. If you are already in pain, most of those receptors are already taken, right? They're already been occupied. And so the pain medicine is not going to be as effective. So I try to recommend, take pain medicine early, take a slightly higher dose. And the goal is that you only need that one dose to last throughout your cycle versus having to continually take multiple mini doses, because that's not good either.
When you said those pain receptors are already responding, I'm just imagining them screaming.
Yeah. 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 Imagine I usually imagine almost like a cup and you have a little ball that comes in and then most of them are already filled, right? If you're in pain, most of those little cups are already filled with balls. And then the pain medicine comes in. It's like, where am I supposed to go? And so it's not going to be as effective. There's not as much play.
Well, okay, so too, what else do you think, what are some other common things about the period that you think that people need to know about?
The other thing that I think is really important is that our cycles are really truly tied to our fertility. That is the biggest drive of the biggest drive of the cycle is trying to get pregnant every single month. So that's really what your body tries to do. I always find this fact interesting, but I'm sure some people may have heard it, but you were born with all the eggs you will ever have. So in your mom's belly, you already carry all of the eggs you'll ever carry in your lifetime. So you start with about 6 million eggs in utero. At birth, some of those eggs have already kind of disappeared, and then you are only left with 1 million. And then by the time you start puberty, you have about 300,000. And then menopause is when you hit 0. And so we are constantly seeing this decrease in our eggs. Now, ovulating, so producing one mature follicle that can become a baby, is the goal of the cycle every month. And so the other thing I like to highlight, because we see patients question fertility and cycles and they kind of link it together, and they're absolutely correct, is that you ovulate only one day in between the start of one cycle to the start of the next. So to put it in perspective, out of 365 days, you have about 12 to get pregnant. And so the egg takes only about a day to travel from when it pops out of its little cyst in the ovary. It kind of pops out, it travels down the fallopian tube, makes its way into the uterus. That's about a day's journey. And so if sperm is not there waiting for it in the fallopian tube where fertilization has to happen, you're not getting pregnant. And so what extends that time is actually the cervical mucus. So your body physically changes in preparation for fertility. So a lot of women notice, their libido goes up. So you know what? Maybe your partner's looking a little bit cuter than usual because your body's trying to drive you towards that, right? You start to produce a little bit more discharge, a little bit more natural lubricant. and it changes. It tends to start to look like a clear mucousy color, and that's actually coming from the cervix. Even your body temperature changes, and so your body makes all these changes in preparation for pregnancy. And so that cervical mucus actually allows sperm to live up to 5 days in the fallopian tube. So yeah, so that's the crazy part. So your egg has this one opportunity, your body tries to extend that window with cervical mucus and sperm. And then if nothing happens in the fallopian tube, that's it. Everything just comes on out and you just start that cycle again. But I think it's very important that when people talk about fertility, it is actually very difficult to get pregnant naturally. It takes most couples about a year to get pregnant. And that's with people who are tracking their cycles, actively, kind of knowing when their ovulation is, timing out intercourse. That's about the window of time it takes. And so if you are having, regular cycles, it's easier to pinpoint that time. And there's no ovulation test kits that you can buy. But if your cycles are irregular, it's very difficult to pinpoint. Or if one of these other factors are not present, right? Like if the sperm isn't what it needs to be, and it's not able to swim up to be in the fallopian tube, or if the cervical mucus isn't the way it's supposed to be, or if you're not ovulating right at the time you expect, you won't be able to become pregnant. And so that's always something I like to mention, because I think a lot of people see other couples get pregnant and they're like, oh my gosh, they just started trying and it just happened. And I'm like, it takes a lot to actually do that, and not to stress out about that, because sometimes it does take time. And for women, the more we stress, the more that stress hormone throws off our body's natural hormones and actually makes it harder for us to get pregnant. And most people I'll see become pregnant after they're like, oh, we stopped trying and then we became pregnant. I'm like, yes, because you weren't stressed.
Yeah, and I could just imagine that with having the stress of, trying to have a baby and it not being successful, like sex then becomes a job and it doesn't become,
Yes.
as enjoyable anymore. And I can recall, like, whenever I was trying, I was having the worst time getting pregnant with my second daughter, who's now 15. And it was just, it was just tough. It was just tough.
Yeah. Our libido changes pretty kind of normal. It's very, it ebbs and it flows and it kind of changes throughout our lifetime. I think absolutely that stress from trying for a pregnancy is a big factor, I think, for a lot of women, because women get very kind of hyper focused on, how am I feeling? What's my body doing? What's going on? Timing things out. And then it can be almost like very transactional, right? Like you're like, we have sex so I can have baby. and then, yeah, it does. It takes the fun and the spontaneity out of it. And we, in our office, we actually see a lot of patients that come in for complaints about a low libido for a variety of reasons. And so the thing that I try to explain to patients is that our libido kind of starts off like very high when we're young, and in our early teens or 20s, most of us have a very high libido. And then through the years, it kind of starts to decrease. And one of the reasons it does that is because your drive to have a baby starts to decrease too. So the closer you get to menopause, the less your body needs your libido, because the less your body needs to have a baby. So it kind of ties to that kind of, so most women, as they get closer to menopause, the sex drive really becomes like drastically lower, because it's kind of tied to that. So it's kind of tied to the changes in the hormones, the changes our body goes through. One of the things that I like to tell people is that women also produce testosterone, right? Just like men also produce estrogen. Testosterone in both men and women drives sex, that sexual desire, that libido. And in women, when we hit 30 or in our 30s, our testosterone drops by half and then just continues to decline from there through the remainder of our 30s and 40s and 50s. And so most women really in their 30s, they kind of start to notice that libido decreasing. The other thing is that women are also going to experience other times of hormonal changes. So, right, and menopause is a big one. The other one is a lot of patients will notice after having a baby, the sex drive changes, because your body is producing a lot of progesterone. and you just had a baby, your body is really trying to give you a strong signal of no, we don't want another baby. Don't even let anyone get near you. That is it. No more of this. We're closing the factory right now. And so a lot of things your body does, right? Because you get increased vaginal dryness after the baby. So sex is uncomfortable. You're worried about your baby, right? You're trying to nurse your baby, watch your baby, take care of your baby. Your body is really kind of geared towards taking care of your baby, the one that you have right now, and it's not really geared towards having a new one. And so that's where we can see some fluctuation with the libido too. I hear a lot of that. I went through it when I had my son. I think pretty much most women go through it. And we are also very women, in terms of their sex drive, it's kind of more of like a physiological or a mental aspect to it too. I find a lot of my patients who have a lot on their plate, right, whether they're moms or not, if your mental to-do list is super long and you wake up already thinking about, okay, at this time I need to do this. I got to go pick up, such and such from this place. Sex is at the very bottom, right? We are very practical in our day, right? Every minute is accounted for. So we're trying to get things done, trying to be as productive as possible. There's not as much free time, right? So at the end of the day, you have this little kernel of energy. And when your husband or your partner starts kind of come up to you, you're like, this last little bit is for me. Okay. And that happens a lot. And so I try to also tell women that it's a little bit of hormones, a little bit of you. And so we can help a little bit with the hormone side, but you also have to put in some effort on your side. So whether it be asking your partner for help, right, to take away some of that mental burden, right? Can they help you do something around the house? Can they help you with the kids in any way? Free up that, 15 minutes for you just to kind of decompress and just to kind of get back to just a little bit more of a resting state. And that's where you're going to be like, oh, sex doesn't sound so bad. And so that's another thing to kind of keep in mind too. So you kind of have a couple different factors kind of really stacked against you whenever you're talking about libido for women. But we do have medications to kind of help on the hormonal side of things. But just know there's kind of like a couple different things, and you kind of have to take care of all of them to kind of benefit.
Wow. Hey, I can totally relate. After I had my baby, the last thing that I wanted to do was have anyone come near me.
Oh, oh yeah. Unless they were going to take the baby.
If you're gonna take this baby, then come over here. But if not, get back.
Yeah.
Like, oh wow,
Oh
and
yes.
that's so fascinating. The way that you were describing how the cycle and the libido train are like literally on the same track. I can totally see it. Wow, that is so cool. Okay, you guys, I know y'all are enjoying this interview as much as I am because this is just so much, it's so much good stuff here. And okay, but we're nearing the end and I have one more question for you. And this came from one of our listeners. And she said, hey, my periods have been irregular because I think I might have fibroids. What exactly are the symptoms?
Yes. Oh my gosh. We see so many patients with fibroids in our office. I'll kind of start off with what the typical patient is. So we see fibroids more common in African American women, and we see fibroids cause more problems in women in their 30s and 40s. So there's a very kind of big population group that we see there. Now we can see, fibroids in all age groups, but that's where we really start to see it cause those bleeding issues. So fibroids are a muscular growth. So your uterus itself is a muscle, and it kind of lays in this nice flat U-shaped pattern that gives you your little uterus. Fibroids then form this little ball of muscle on top of it. And so you have 3 different layers of the uterus, and fibroids can grow in any of the 3 layers. When they grow on the innermost layer, it can distort the lining. So your lining is normally a nice straight lining, so when things shed, they just come right on out. Fibroids can start to grow into that cavity, make it all lumpy and bumpy. And so then as your lining is trying to shed, it's getting caught up in all these crevices. You're forming clots and you're having to cramp harder to clear those out. And so they're not cancerous, though. That's a good thing. They're not cancerous, but they can cause a lot of issues for our patients. So most common symptoms we see with fibroids is going to be heavy cycles. So they are bleeding and they're changing more than like an overnight pad or a super tampon an hour. So every 30, 45 minutes, they're changing on those heavy days. Those are the ones that are coming in with those big clots that we see too. So those very large, kind of like I've seen golf ball, baseball, people have described it in a variety of things, but those big clots. And then really strong cramping. So because those fibroids are muscle, imagine, because the muscle almost feels like the muscle you'd feel at your bicep. It's very strong muscle. And so now you're having all these growths that are increasing the size of the muscle. The cramping intensity is much, much stronger in patients with fibroids. The other thing is that patients can also get abdominal pain because the fibroids take up space within the cavity. Other kind of weird symptoms that might be associated with really large fibroids, urinary frequency. So the uterus kind of, in most people, kind of lays on top of the bladder. And so as it gets heavier with fibroids, it puts more pressure on the bladder. So women with large fibroids they feel like they're having to pee all the time. Or if you have a lot of fibroids and it's kind of leaning on the back, so on the rectum side, those women can have issues with constipation and difficulty having bowel movements. And then in some women too, they can have pain with intercourse because the uterus is kind of riddled with these really dense, thick fibroids on it. Anytime you have sex and basically the penis kind of pushes on the cervix and it pushes on the uterus, kind of moves it and causes a cramping sensation, and it can cause pain for them too. So we see patients for a variety of symptoms. Now, the number of fibroids and the size of the fibroids does not equal the symptoms we see. So we have some patients that have a bunch of little mini ones. And by mini, I'm talking maybe like 1 centimeter, 2 centimeters. So the size of like a green pea or the size of like a grape, in significant pain, bending over, they can't go to work. And then we have some people that come in with a huge like 4-month pregnancy equivalent of a uterus. And all they notice is like, my abdomen's kind of firm and I can't lose weight. So strange, super, super weird. But I'd say most people have symptoms, but we do have some that come in with just no symptoms whatsoever. And there are just a variety of different treatments available, but something to keep in mind is that if you have those larger fibroids or those fibroids that really push into the cavity, they can affect fertility. And they affect it in that when they push into the cavity or when they're super, super big, they are taking up the space that you would have for your baby. And so if your uterus already sits at 20 centimeters, right, which is at belly button level, that's like a 4-month pregnancy. So if you already have a 4-month pregnant uterus, you're not going to fit a 9-month baby in there. And so that's where we can see patients have issues with fertility too. So it can kind of cause a couple different issues for patients, but I would say those are kind of the most common things we see.
Wow, that is crazy.
Yes. Yeah, those visits are very long visits with me. I have like pictures, I'm drawing stuff out, I'm showing them models because that is, for some people, it's very shocking to really figure out what fibroids are and just get some clarity on why they were feeling the way that they were. And to realize, like, I was not going crazy. It was my fibroids. And then to give people just a little background, because I have some patients who have fibroids and did not know that bleeding that much was not normal, because women don't really talk about it. They're like, wow, I just thought everybody bled like this. I'm like, no, not everybody does that.
Wow. You know what? I am so glad. I am so glad to be able to have this type of conversation with you because I have learned so much. Like I had no idea, and that it's just wow. There's so much to it. I know that we are very like complicated species, but wow.
Yes. Oh my gosh. I know. And that's just like a little drop in just women's bodies and how they work and of course, and how it can go wrong, right? How things can kind of change and deviate from our normal pattern.
Incredible. Well, oh my gosh, this has been, like I said, oh my gosh, I feel like I've just learned so much. And so I've enjoyed this so much. This has been a very enriching conversation. And I just want to thank you for taking the time out to join me today and share all of this information about periods and fibroids and libidos and fertility and what didn't we talk about?
Yeah. Oh my gosh. Yeah. There's so many things because I know we touch base on like just like even like things like STDs or
Yes.
contraception or vaginal discharge. I mean, so many things out there. But I think this is one of the things that kind of will establish that baseline for a lot of people. And hopefully, in the process of this, we got a couple more questions just kind of answered through the process of this talk. Because I know, yeah, we did not get to a lot of questions, but
You know
we
what?
tried. We
We
tried.
tried, we tried, and I hope that there will be a next time.
Yes, yeah. Oh, thank you.
Yeah.
Yes, yes. I would love to come back.
Thank you, thank you. Okay, you guys. Well, this is Vickie, and I just and too, and we want to thank you guys for joining us today. And hey, you guys, remember to love everything, everyone, and most importantly yourself. This is Vickie, wishing you guys a very, very happy Wednesday. Thanks, and take care. Bye bye.